the ability of the agent to bind to tissue surfaces and be released over time. This again is a very favorite question in your Viva. What is substantivity? Kindly remember the definition very well. Apart from the previous two classifications what we saw, that is based on the action what they have and based on what chemicals they are having or the agents, active agents what they are having in them, we can further classify as well, wherein first generation, second generation and third generation are there. Wherein first generation would be the phenolic compounds, quaternary amine compounds, antibiotics, halogens, metallic ions, herbal extracts, anti-plaque enzymes and oxidizing agents belong to your first generation of chemical plaque control agents. Second generation would be your bisphosphonates and the bispyridinates which are there, and the third generation would be your dalmophenol. So this again is important one wherein they might ask in an exam paper or even in Viva VOC classify chemical plaque control agents. You can mention any of the classifications which are there. The most important now what we are going to discuss is chlorhexidine. It is very important for your everyday practice. It's very important for your theory papers and your Viva VOCs which are there. So all these slides I have taken both from Carranza and from Jan Linde. So I request all of you to make a notes of the same, or anyways you have the slides now. This is very important theoretically, clinically, even after you graduate and go. Chlorexidine is very important. So now coming to what exactly is chlorexidine. As previously mentioned, it is a bisphosphonates in nature. And there are three forms which are there. In that, first form would be the digluconate, the acetate and the hydrochloride salts which are there. So how exactly did chlorhexidine come into use as a chemical plaque control agent which is there? Previously, it was used as an antiseptic on wounds and even for pre-surgical preparation. That is how the origin of chlorhexidine came into as an antimicrobial agent, as a disinfecting agent, and finally it evolved into what is called as a chemical plaque control agent. And the first and foremost definitive study implying chlorhexidine is very good for chemical plaque control or as a chemical plaque control agent was done by Lowe and Shayad, who rinsed or experimental basis. Rinsing was done for about 60 seconds twice a day and 10 ml of a 0.2% in absence of normal tooth cleaning, inhibited plaque regrowth and development of gingivitis which was there. So this was one of the first definitive study which actually brought chlorhexidine as a chemical plaque control nature which is there. Now, because of the dicationic nature, that is two cations, dicationic, two cationic nature of chlorhexidine, they are extremely reactive with anions. I hope you remember your basics, anions and cations which are there, and because of which minimizes absorption through skin and mucosa, no systemic toxicity or teratogenic effect, very rare hypersensitivity reactions, and very rare neurosensory deafness if it is being used as an antiseptic in the middle ear. And because of all these nature, chlorhexidine is one of the best antimicrobial agents or the chemical plaque control agents we have till date. And even better is broad antimicrobial agent, that is it can act both on gram positive and gram negative bacteria which are. Since we have seen what are the actions of chlorhexidine, let us see some of the side effects of chlorhexidine as well. The first and foremost side effect would be what is called as the brown discoloration which is there. This is most often very commonly found side effect. That is because of four mechanisms. This again is very important. First mechanism is degradation of chlorhexidine molecule releasing chlorochloraniline, which is a staining, which has got a staining property which is there. That is, once you rinse the oral cavity with chlorhexidine, the chlorhexidine molecule releases parachloraniline which is there and leads to the discoloration which is there. And you have something called as catalysis of Maillard's reaction. I hope you guys remember what is the meaning of the catalyst. That is, when you have, it's a non-enzymatic browning reactions of all the proteins and the lipids which are present, wherein chlorhexidine acts as a catalyst agent which is there for this particular Maillard's reaction which are there. Then comes the protein denaturation with metal sulfide formation. That is, you have a whole lot of protein denaturation because of the desformative epithelial cells and the bacteria which are there, which react with the metal and form sulfides, metal sulfides which are there, and that eventually leads to the brown discoloration. Next, you have the precipitation of the anionic dietary chromogens. That is, you have various chromogens which are there. Chromogens are coloring agents which are present in tea, coffee, and the red wine, or even the toffees what we chew, and they react with the or precipitate the chromogens which are there, eventually leading to staining. So there are four mechanisms: brown discoloration due to the chlorhexidine. First one would be degradation of chlorhexidine molecule, releasing the para-chloraniline which is there. Second one, it acts as a catalyst for the Maillard's reaction, which is a non-enzymatic browning reaction. The third one would be the protein denaturation with metal sulfide formation. And fourth one would be the precipitation of the anionic dietary chromogens which are present in the tea, coffee or any food substances which are there. Next, we have the taste perturbation. Kindly remember this taste perturbation, because when we are going to show or study about how to prescribe chlorhexidine, you will understand why it is important. In the previous, in your clinical postings, you must be knowing that I always mention, when do you always prescribe chlorhexidine? We always tell that it is after having a breakfast in the morning, or that is the reason why we have taste bud. And you always tell the patients not to rinse off immediately after you drink, or do not eat or drink anything immediately after you rinse with chlorhexidine. That is the main reason, because if you eat or drink anything after rinsing with chlorhexidine, you definitely have very bitter taste which is there. And then few cases of oral mucosal erosion which are there, unilateral or bilateral parotid swelling, and of course one of the other greatest disadvantage of chlorhexidine on a long-term usage would be enhanced supragingival calculus formation, which is going to be coming to how exactly does chlorhexidine act. I've already mentioned in the first slide saying that it has got a high antimicrobial agent. So it is an antibacterial substance wherein the antiseptic binds strongly to the bacterial cell membranes which are there. In low concentration, it is mainly a bacteriostatic, and how it acts is it results in increased permeability with leakage of intracellular components including potassium which is there. And at high concentrations, it is mainly a bactericidal, wherein there is going to be a precipitation of bacterial cytoplasm and cell death which is going to happen. And chlorhexidine is very readily adsorbed to the pellicle coated surfaces, and once adsorbed, it has got a 12-hour action which is nothing but substantivity, that is a persistent bacteriostatic action which is there. So here I would like to tell you one thing, why we prescribe chlorhexidine twice daily. That is because once absorbed onto the tooth surface, it has got a good 12-hour action which is going to be there. So now I hope you can understand why we give twice daily and why we give the post-op instructions which are there. Now there is something called as pin cushion effect, wherein it means that it is going to act as a pin towards the bacteria and provides or a comforting zone for the tooth surface which is there, wherein one cation attaches to the pellicle and other with the bacteria attempting to adhere to the tooth surface. So this is something called as pin cushion effect, which is very peculiar to chlorhexidine mouthwashes which are there. Now, having known the advantages or how exactly it acts and what are the disadvantages of chlorhexidine, what are the different chlorhexidine products which are commercially available? First would be, of course, mouth rinses, which you all know. The most common or available in India would be 0.2%, which is 20 milligram dose in a dose of 10 ml per rinse. That is because Why we give 10 ml? Now I hope you can understand why we always write 10 ml per rinse, which is there, or why I always stress on writing 10 ml per rinse. That is because the Chlorexidine mouthwashes what we use is of 0.2%, and what we require is only about 20 milligram dose. So to achieve this 20 milligram dose of the 0.2% mouth rinse what we are using, we require what is called as 10 ml, which is there. The other percentage which is available, or the other concentration which is available, is something called as 0.12%, which of course is available only with Colgate, okay, Chlorexidine in India, and it is to be required in 18 milligram dose, and we prescribe it 15 ml per rinse. So most common what we use is the 0.2 with a 20 milligram dose and 10 ml of the mouthwash, which is essential. Of course, gels are there wherein you have 1% gel, 0.2 and 0.12% gel. 1% gel, if you can recollect, in treatment of aggressive periodontitis in full mouth disinfection, 1% gel is used. Sprays, of course, 0.1 and 0.2%, wherein 1 or 2 milligrams would be delivered in one spray. Toothpaste were previously existing, now no longer. We'll come to know the reason why. Varnishes, of course, prophylaxis against root caries, and slow release vehicles, that is local drug delivery, Chlorexidine chip. All of you know Perio chip, which is there, which is a Chlorexidine delivery chip. Now let me tell you the reason why exactly toothpaste form was not very feasible. That is because, as I mentioned you, Chlorexidine is a bicationic in nature, and I told you it has got a very strong action with the anions. Your toothpaste has got an anion which is the sodium lauryl sulfate, and when this Chlorexidine compound binds with the sodium lauryl sulfate, which is an anion present in the toothpaste, the Chlorexidine action gets nullified. No longer the Chlorexidine can give out its action. That is the main reason why Chlorexidine as a toothpaste is not very feasible, and this is one of the main reasons why we tell the patients in the night time, please brush, give a gap of half an hour or 40 minutes, and then use Chlorexidine mouthwash, which is there. Okay, so now we already know why in a prescription we are giving 10 ml per rinse, why we are giving twice daily, and why we are giving the post-op instruction as well. Now the question comes, in which patients do you indicate Chlorexidine mouthwash? As an adjunct to oral hygiene and professional prophylaxis, post-oral surgery including periodontal surgery or root cleaning procedures, as a part of full mouth disinfection in patients who are having jaw fixation, in mentally and physically handicapped patients who are unable to achieve adequate mechanical plaque control, then in high risk caries patients, recurrent oral ulceration, removable and fixed orthodontic appliance wearers. Of course, if you're giving on a long term, please do diluted. Denture stomatitis, oral malodor, and immediate pre-operative Chlorexidine rinsing and irrigation. Especially in the present scenario, Chlorexidine does work very well, and subgingival irrigation as well. So these are the indicated candidates for our Chlorexidine mouthwash usage. Before we jump into the next part of the chemical plaque control, which is mainly oral irrigators and small part of disclosing agents, I would like to again stress on Chlorexidine. So in the prescription, we normally write any mouthwashes, any brand we prescribe, 0.2%. You know it is commercially available in India. Now you know why you are exactly giving 10 ml per rinse. You do know now why you are giving twice daily, and why for a short-term period. You cannot give months together of Chlorexidine because of the adverse effects which are there. And what are the most important post-op instructions? The first important post-op instruction would be undiluted if you're giving for a short term of 1 or 2 weeks, diluted if you're giving for a long-term period, which is that. Then twice daily. You know the reason, because Chlorexidine is having an action of 12 hours, and the substantivity plays a very important role over there, and that's the reason you give twice daily. And why do you give 10 ml of 0.2%? Because you need to achieve a 20 milligram dose, which is there. And of course, what are the other post-op instructions? Morning, always use it after your breakfast, because you don't want the chlorexidine to be rinsed off 1 point, and to avoid the bitter taste, we do not tell the patients to rinse off immediately because you want the chlorexidine to be staying over there. And then you have the next part of it wherein 9 times you ask the patients to brush, give a gap of half an hour to 40 minutes. That is because even you brush and rinse, there will be some amount of your sodium lauryl